Vomiting and diarrhea in kids. So kids are just little adults. Everybody knows that except the pediatricians. But in this area, there is this kind of concern that you better not give these kids stuff for vomiting. You better not give them stuff for diarrhea because they may be particularly prone to some problems. Number one, if the kids are nonverbal, we may be masking some more serious kinds of things if we give them medication like that. They may be more prone to side effects. There's this kind of belief that, you know, if you give a kid Compazine, they're going to be more prone to these dystonic reactions. I don't know whether, honestly, whether that's true or not, because I've not seen any papers on it. And I've been, since 1977, I've been the one who has looked at all of the articles. What you have in your, each month we go through 600 journals. Well, not every journal is published every month, but it's about 600 journals a month. And we list every article that relates to emergency medicine, and then I get a substantial subset of those. So I have a stack like this every month that I go through. So I think I would have found and noticed papers that talked about these issues in kids specifically, if it applied. And I haven't found any articles that said kids are more sensitive to phenothiazines. You know, it's a belief, but I haven't seen any papers that said, well, we gave them this, we didn't give them that, and we compared the two. So I think that may be true, but I don't know that there's any data to support it. So there's this, and then there's lastly this issue about sedating these kids and maybe causing respiratory depression, et cetera, et cetera. And so that issue resulted in Promethazine Phenergan being black boxed in 2005. And by far, I think Phenergan was the most commonly used drug for pediatric vomiting ever. I don't know how well it worked or not, but it was routinely used. People would stick a suppository up a kid's butt, and you would hope and keep your fingers crossed, and you'd give them a little water, and if they held that down or something like that, then you would send them home. And some people would prescribe it. However, the American Academy of Pediatrics did come out, and article number 1 said, let's look at the use of this stuff and who's using it, because the American Academy of Pediatrics in 1996 said that they were discouraging the use of antiemetics in kids under 5. So this is a Medicaid look at 20,000 kids, 1 month to 18 years old, diagnosed with gastroenteritis, looking at how many of them had a prescription for Phenergan filled within 3 days. And it was 9% of the kids, which now you could say that's a lot or a little. Doesn't seem like very many to me. And who was prescribing this stuff? Well, if the pediatricians are viewed as a kind of like the baseline, who were the ones who were kind of the nasty doctors prescribing this? Well, by far the odds were greatest that the emergency doctors were prescribing this. They were twice as likely to prescribe it than pediatricians. GPs and family physicians were like 1.5 times more likely to do it than pediatricians who had gotten the message. So we apparently had not gotten the message that you're not supposed to use this stuff. But the fact is that this paper also looked at subsequent visits for adverse effects. Now, you know, you can't say for sure that they caught all of them by any stretch of the imagination. But it came out to be 1 in 250 kids was documented as having some kind of adverse effect. Was it serious adverse effect? Probably not. So the conclusion here was that this paper said antibiotics are prescribed a lot for kids. You know, is 9% a lot? That doesn't sound like it is a lot for me. But that has been effectively taken away from us because they said, the black box said, don't use this under kids under 2, which is just the kids you'd like to use it in. Be very careful in using it in kids and older kids. They said, to justify this black box, that a whole bunch of dosing regimens have been associated with depression in kids. So there's no consistent way to give this stuff safely, and avoid using other drugs that would also maybe make respiratory depression and sedation come in kids as well. Any of you continuing to use Phenergan? No, the people not in the States, you don't have to deal with this. So the Canadians and the Australians and those kind of people, you use Phenergan? Because you're not killing kids over there with it yet. We are. This black box thing is really kind of unfortunate because Well, you know, you can look at the numerator and say, well, there's these cases, but what is the denominator? The denominator has to be a bajillion doses of this stuff. The same thing is true for Droperidol. Droperidol in this country was black box because of QT prolongation associated with some dysrhythmias. But there's a bunch of drugs that do QT prolongation, and Droperidol is in the family with haloperidol. Haldol causes QT prolongation. And there is an increased risk of sudden death in psychotic patients. So patients who are taking Mellaril or any of the traditional antipsychotics, they have an increased risk of sudden death. And at the top of the list was Mellaril in terms of being associated with sudden death. Now, Mellaril is a drug from the 70s, and maybe it's not used very much, but there's this kind of idea that this is a common issue. And now, any of you using in the States any Droperidol? Some people basically said, screw it, I'm still using this stuff. In my experience, it's been safe. They want you to do it. You doing EKG and none of that stuff?
Usually, yeah. I just check the QT just because of that one weird, you know, if you find a weird case of somebody with low magnesium or something, it's got a long QT.
But does that mean that you do a 12 lead?
Yeah.
Because, you know, what does your hospital charge for a 12 lead? It's like $200 probably, kind of thing, to use a 30-cent drug, you know. But it effectively, you know, there's some people still using it, but they're effectively stopped its use in the States. Because even if you wanted to use it, your hospital said, listen, that's fine, but we're not going to stock this anymore because of this black box. Because every time you get sued, they get sued. And they're going to say the Pharmacy and Therapeutics Committee should have basically put some restrictions on this thing. They didn't. You know, so they're going to drag everybody into this thing. So, oh, yeah.
People who risk-myosin increase odds of risk for sudden death is double.
Yeah. Now, that's also kind of using the statistics in kind of the worst way. Because instead of 1 in 50 million, it's 2 in 50 million. So the odds is double. Yeah. But what is the absolute number kind of thing? It becomes the issue. So unfortunately, they took a drug that we used. I don't know how good it was, but they took it away. And so we replaced it with good old, brand new ondansetron. Here was an opportunity to use this really fantastic drug that was used in chemotherapy patients, and it was really, really considered to be a terrific drug. Now, wouldn't sedate you, had no side effects of any consequence kind of thing. And so now that's basically replaced the Phenergan. You could almost consider the conspiracy theory here, where they blew up Phenergan so that people would use ondansetron, which is almost like the conspiracy theory that people have said with regard to Droperidol. There is a reasonable case that all of these cases of Droperidol causing QT prolongation and arrhythmias were all reported in a relatively short period of time. And there's been journal article after journal article talking about what a coincidence. All of these cases are reported, a lot of them from Europe, where they were using doses way out of line compared to what we were using for Droperidol, but that it all came together in the perfect storm to kill this drug. And when Droperidol went away, then you bring in all of the other more expensive drugs to replace it. So ondansetron, we got ondansetron now. Everybody uses ondansetron in the United States for vomiting kids, thinking this is very cool. And the trade-off was it was going to be really expensive to use ondansetron, but we had no choices. They took it away from us. What are you going to do, kind of thing. One of the recurring themes in this stuff on ondansetron is it is not as the miracle drug that we think it is. You take a look at the paper number 2, a Polish meta-analysis. How many Polish meta-analyses you've been reading this? You know? 490 patients between the ages of 1 month and 22-year-olds. So the 22-year-old is the mother of the 1-month-old. The doses varied. Some are IV, some oral. We don't want to be given this drug IV. 30% decrease in vomiting sensation, 30%. Number needed to treat to get vomiting cessation was 5. So 4 didn't get it, 1 did. But the thing is, that's a little misleading. You know, stopping is one thing. Decreasing is something still that's a valuable thing. Decreasing a lot or a little, that's good. What about the likelihood for IV rehydration? Number needed to treat to prevent IV rehydration was 7. Well, IV rehydration is all or nothing. You are either doing it or you're not. So this is probably this number is a little bit more meaningful here. Small increases in oral rehydration intake occurred. No effect on hospitalization rates. 3 studies noted increased diarrhea. This is, when did this diarrhea come on? 24 to 48 hours after you give this stuff. So it's like, can you connect the dots and say this drug that we gave one time caused diarrhea 1 or 2 days later? But there is this recurring issue of diarrhea that comes up. And look at the conclusion. The Polish people said, insufficient evidence to recommend routine use. Wow, we thought this was going to be the miracle drug kind of thing, and these guys, they back off. 3 is a paper comparing IV ondansetron versus dexamethasone. I never knew that dexamethasone was an anti-vomiting drug. Have you heard of that? I haven't heard of that either, but these are cases of mild to moderate dehydration. As soon as you see the words mild to moderate dehydration, the word IV should leave your mind, because those people do not qualify for IV rehydration in mild to moderate. We'll talk at the very end about a summary of what we did last year or was the year before about rehydrating kids. But mild to moderate dehydration is about oral rehydration therapy. So they're talking about IV use of ondansetron here. Basically, the controls got nothing. Dexamethasone, 15% of them failed oral rehydration, and 4% of the kids got ondansetron failed oral rehydration. So the gross numbers here look pretty decent. The first they give this stuff either by weight or by age. Weight or by age. Here the paper number 4 is we're going to give it by weight, which seems to make a little bit more sense than giving it by age. But they're just picking doses out of a hat anyway. Because if you have a drug that doesn't hurt you, how do you know how much to give, kind of thing? So this is one where they looked at kids between 6 months and 10 with gastroenteritis, again, mild to moderate dehydration. Prospective, double-blind, weight-based, the doses are there. You could give a dose, and if the kid vomited within 15 minutes, you could repeat that dose, because we don't think the dose is going to harm you no matter what we give you anyway. Vomiting during oral rehydration, it cut it in half. It went from 35% to 14%. So the number needed to treat, 35 minus 14 is 21. 21% absolute difference. That converts into a number needed to treat of, you just turn it around, 20 into 100 is 5. Number needed to treat is 5. The number of episodes of vomiting went down from substantially. IV hydration was required in 6. Number needed to treat to prevent that was 6, kind of thing. No difference in the hospitalization rate, which is small to begin with, 4 to 5%, kind of thing. And the mean episodes of diarrhea was 3 times more likely with ondansetron. So this may be one of the papers in the meta-analysis that the other things supported. 5 is a review of 4 randomized controlled trials of multiple antiemetics, 358 patients, published in June of 2005, generally positive for ondansetron. But the part of this paper that I liked is it said, notes 2 studies in which metoclopramide, Reglan, was no better than placebo. I have no idea why metoclopramide is viewed as some people it's kind of the drug of choice. I don't think it's all that good, to tell you the truth. So that's why I like number 5. Children's Hospital of Boston, IV studies, number 6. Look at the admission rate in this study. 26% of the kids getting ondansetron were admitted to the hospital. 30% of the controls. This sounds like it's Bangladesh or something like that. Number needed to prevent at 1 admission was 8.5. Now the next paper, 7, is where they give it by age-based. The other one, 4, is weight. This is age. No vomiting during the ER stay went down only a little bit, 87% to 65%. So 87%, 65%, a 12% absolute difference. Number needed to treat, 8. less likely to be hospitalized, more diarrhea, 3 times more likely to have diarrhea, and more ED revisits. The economics of ondansetron, it became generic in 2005. No, it became generic in at the end of 2006, and now it's supposedly, if it's generic, going to be cheaper. Yeah, it's a lot cheaper if you get it in Canada, but if you look at drugstore.com, prices for ondansetron generic are still pretty expensive. This stuff here this was done in this article was this talk was put together in November. So generic ondansetron is $19. Brand name was $24.
This increase in diarrhea that's being noted, I mean, these kids have been treated for gastroenteritis, which is vomiting diarrhea. You're treating the vomiting part, and then you notice an increase in diarrhea. Well, it doesn't seem like anybody's treating the diarrhea part, so that would be relatively increased if you reduce the vomiting.
Well, some of these kids, they're kind of loosey-goosey about the term gastroenteritis, because you're right. Gastroenteritis means you have diarrhea and vomiting. And, people put that down for, you have all of the missed cases of appendicitis, they all get diagnosed as gastroenteritis. And then you look at the chart, and there's no diarrhea. There's just vomiting kind of thing, because you don't expect any kind of diarrhea in a case of appendicitis kind of thing. So I do think people need to be a little bit more careful about the throwing around this term, because vomiting would be the gastritis, but you need to have diarrhea to have the enteritis part. And maybe they were not as careful in terms of making the differentiation here.
And I guess the question is, was it clinically significant diarrhea? In other words, was it just a couple of episodes of diarrhea? They didn't bring him back to the hospital for it, or did they?
Well, actually, number 7 said there was more ED revisits, but it was small, 5% versus 0%, which is kind of probably. You don't have any choice, really.
Well, as far as the cost of this stuff, I mean, it's the ODT tablet that's so expensive, right? Yeah. And our pharmacy is trying to get us now to use the injectable solution orally.
Really?
Yeah, because it's so inexpensive relative, but it's the ODT tablet that's so very, very expensive, and the other regular tablets aren't that high. So,
Well, I think actually that these prices that I put here, I don't think that these are current right now, because
the last I saw generic was $10 and
$10 per tablet.
yeah, $10 per tablet. Zofran itself is like 20, a little over 20.
Yeah, I think it's actually cheaper than that, because I bought some of this stuff at the hospital just to have around kind of thing, and it was surprising. It was like nowhere near $10 a tablet. It was like $1 or something like it a tablet. So maybe it has become more economical. All of the generic stuff is made in all of the versions that the trade name stuff is. They have liquid, they have the orally dissolving tablets, they have, you name it, the generics come in the same variety. So basically, we're now using ondansetron. The thrust of the papers is, yeah, it seems to be safe. It's not a miracle drug by any stretch of the imagination. And there may be this little bit of diarrhea, no big deal kind of thing.
One other thing there, Rick, is that if you look at what they do for cancer patients, they give them routinely, they start off with 32 milligrams.
Well, see, I think that's one of the issues here is it's pretty clear that these doses for kids are just being pulled out of your head kind of thing. And that maybe we are not being aggressive enough. And what we need to do now, because this drug doesn't seem to hurt anybody, is we need some dose ranging studies rather than just using these empiric studies kind of thing. Because there are things where kids tolerate drugs substantially better than adults do, like acetaminophen. The likelihood of you getting toxic in a kid with acetaminophen is really, really small, because they have the P450 pathway is different for them than it is for adults. So their ability to make the toxic intermediary metabolite is substantially different than adults, same dose, same per kilogram. And so we need some better studies, because if everybody's going to be using this stuff, and now it's going to be the relatively inexpensive, we need to kind of say, is this the right dose? And I don't think we know that. So now we got the diarrhea, vomiting more or less under control. The next one is about the Pepto-Bismol. 2 papers that say Pepto-Bismol works for diarrhea. The first paper compared two doses, 100 milligrams per kilogram per day versus 150, and the second uses 100 milligrams per kilogram per day. The first paper said we found no difference between these two doses. So for all practical purposes, we're talking about 100 milligrams per kilogram per day. The first study looked at 252 boys between the ages of 3 months and 5 years old. These were admitted kids for diarrhea. No notable difference between the two doses. Bottom line, somewhat better than placebo regarding length of stay, total stool output, and total oral intake. Similar kinds of results for number 9. Lower total stool weight on days 2 and 4, improved stool consistency, fewer stools on days 3 to 6, clinical score significantly better on days 2 to 6, and also less need for IV fluids. And both of these looked at evidence for toxicity because Pepto-Bismol is this issue of bismuth and salicylate. Maybe makes you a little nervous kind of thing. Both papers looked at this. That was not an issue. Blood levels of bismuth and salicylate were okay in number 9. No evidence of toxicity in number 8. So Pepto-Bismol seems to be a reasonable thing to give kids, over-the-counter kind of stuff. What about the real decent stuff for diarrhea now, loperamide? Can you give loperamide to kids? Any of you give loperamide to kids? We're kind of afraid of this one because this is kind of like the narcotic, stop the bowel, kind of thing. You feel comfortable doing this? Admitted or discharged or both? Discharged patients. The first paper looked at 13 studies.
I think when you say kids, you kind of got to divide it up a little because a 6-year-old is different than an 18-month-old.
Yes, that is true. There's a couple papers that get into that. The first one is this 13-study randomized controlled trial look at systematic review and meta-analysis published in March of 2007. 1,800 kids, yes, younger than age 12. Most were only mildly dehydrated. Most got oral fluids. Few had bacterial diarrheas. And they tell you the dosing range there, which is variable, 0.1 to 0.25, so 2.5-fold difference in how much they're giving in these studies. And it worked. Why would you think it would not work in a kid if it works in adults kind of thing? Reduced prevalence of diarrhea, mean reduction in duration of diarrhea decreased by 1 day, reduction in stool counts substantially, adverse events, well, that's what we're concerned about. 10% versus 2% in the controls, 10%. What about serious adverse events? They concluded that that was about 1%. 1 in 100. All of them were in kids less than 3. So basically, maybe that's kind of like the area where you would kind of not want to, but certainly, are you older kids, 4, 5, 6, 7? So the red flag would maybe be kids less than 3 who are having diarrhea. But the other thing, the nice thing about diarrhea is, if you get them to stop vomiting, it's just a matter of filling the tank. And they're generally going to be thirsty, and they're just kind of it's just a matter of just refilling whatever goes in the front end. Out the back end, it's much less of a problem than, frankly, vomiting, which is basically we're not holding anything down because he's vomiting every half hour. So the necessity to give medications for this basically becomes a little bit less. 11 is a study, kids 2 to 11, 258 kids, acute nonspecific diarrhea. They looked at what they said, age-appropriate dosing, and shorter time between the start of treatment and the last unformed stool, and other positive effects were noted, rated as excellent to very good in 60% of the cases versus 46% of the controls. Number needed to treat then was 7. Drug-related adverse events, again, that's what we're looking at, 9% with loperamide versus 4% of controls, how many of those were nasty. And then the 12 and 13 talk about its use in higher doses in hospitalized kids. Number 13 says, it's an old paper, advised against its routine use at these higher doses, and we're talking about admitted kids. But in this, like 13, 300 kids, British study, it stopped the diarrhea. It stopped it. They were using serious doses of this stuff. There's a bunch of papers on probiotics. This is the idea of you're going to use some kind of bacterial-laden thing to probiotics would be used in gastroenteritis due to antibiotics maybe, or some viruses or whatever. Diane, I'll have to call you back. So the problem with this is, if you read studies like number 18, 19, and 20, it says not all bacteria create the same beneficial effect. And look at, you can't even pronounce the names of the bacteria that they're talking about, no less how to advise a parent to get this one versus that one. There is some suggestion that Lactobacillus GG probably produces a modest benefit. So, it's not going to hurt to give these kids this stuff. But we don't know whether it's going to work because we don't know whether we've got the right kind.
Where do you get it from?
This is not Dannon yogurt, by the way. This is not, it's not that. This is health food store kind of stuff, maybe kind of thing. So unless you're really into this and can come up with a name of a product that you can get someplace at GNC or something like that. The last thing is about the reiteration of the antibiotic-induced diarrhea. This paper we covered this paper before, but this is the one that says diarrhea, 11% of kids getting antibiotics get diarrhea, and Augmentin and kids less than 2 are nasty. And when you give both of them, Augmentin and kids less than 2, it's even worse. I just wanted to take a minute to reiterate something that we did in the 2020 Series 25, this is Series 27, 2 years ago. It was about fluid therapy in gastroenteritis. Because people often think that this is complicated. We need to know all these formulas, And the fact of the matter is that it's really surprisingly simple. So I would just like to reiterate the thrust of that half hour. So you need to know basically maintenance therapy in kids. What is the maintenance therapy of kids? Maintenance therapy in kids is 0 to 10 kilograms is 100 mLs per kilo. So a 10 kilogram kid is 22 pounder is a 1-year-older. So a 1-year-old kid needs 10 times 100 is a liter. A 1-year-old kid needs a liter of fluid a day to maintain their hydrational status. This is maintenance, one liter. If you take that and extrapolate that to an adult and say you have a 220-pound adult, that's 10 liters that person would have to drink to stay equivalent to a kid. Reflecting the fact that kids, frankly, do need more water and liquids than adults proportionally, much more water. So if they get sick and they're not drinking or they are vomiting, they are much more likely to get dehydrated because their baseline necessity is substantially greater than, can you imagine saying drink 10 liters of water to somebody? That's your maintenance kind of thing. That's ridiculous. But that would be what extrapolating from a 1-year-old. For the second 10 kilograms of a kid's weight, it's 50 mLs per kilo. And from the 21 and up, it's 20 milligrams per kilo. So all you have to remember is 100 for the first 10, 50 for the second 10, 20 mLs from the third 10 and up, and that will determine how much you should take in a day. The next thing is how much are you deficient. So you make up your mind. Is this kid mildly dehydrated? By whatever kind of standard you want to use. Moderately dehydrated or severely dehydrated. Mildly dehydrated, 50 mLs per kilo. Moderately, 100, severely 150 mLs per kilo. So you examine the kid's skin is doughy, there's no tears, less, well, okay, that's a severe, that's a 150. Kid's still crying with tears, maybe mother says he's not drinking as much as normal, fine, okay, that's a 50. It's certainly by no means an exact kind of process. How quickly do you replenish that 50 to 100? Everybody says, American Academy of Pediatrics, World Health Organization, you name it, the kids who have mild to moderate dehydration should be given oral rehydration therapy. And the criticism in the United States is we have a very low threshold for plugging in an IV and doing that, which prevents the mother from seeing how, in fact, oral rehydration therapy works. The failure rate on oral rehydration therapy in large studies averages out to be in the neighborhood of 5%. 5% of the kids who have mild to moderate flunk oral rehydration and need to get IV. So that's that sippy stuff where you're giving them an ounce or two every 15, 20 minutes, give another ounce or two, another 15 minutes, small amounts frequently kind of thing. Of what? It's Pedialyte, Rehydrolyte, World Health Organization, fluid. It doesn't matter. everybody has Pedialyte, fine. Give them Pedialyte. How quickly do you restore the deficit? In 4 to 6 hours. So you determined that this kid, say for the sake of discussion, is 100 mLs per kilo down. You weigh the kid. That amount of Pedialyte is going to go in 4 to 6 hours. Small amounts frequently. If he vomits once, fine. Here's your ondansetron. Wait a little bit. The idea is not to say, well, we're going to put the GI tract at rest. One of the problems in these kids is they are all calorie deficient. Most of them will have bicarbs that are down a little bit. Most of them, when you check the urine, they'll be a little ketotic because they are now not eating enough. They're not burning calories like they need to, and they are going to start burning fat and generating ketones and becoming a little acidotic. The thrust of the literature on these papers is don't measure electrolytes. Don't measure, this. We have a doctor at our hospital, some full-time faculty at USC. This guy measures electrolytes in all of these kids. It doesn't change what you do. Fine, the sodium's 148. Okay, what are you going to do? And the bicarb, and the BUN's this, and the bicarb's that. The bicarb is low because the kid's starving. Give him some calories and get with it. Mild to moderate, PO, frequent amounts. Fill up the tank in 4 to 6 hours. They were either 50 or 100 mLs per kilo down. So you fill up the tank quickly, then you start refeeding them. What do you refeed them? Full age-specific diet. It's no half-strength formula. It's no half-strength milk. It's not, if they're eating pizza before, they're eating pizza again. Full age-appropriate diet 4 to 6, after you've filled the tank again. So it's really pretty easy. One of the issues is, well, the kids was taking milk, and what about this lactase intolerance and that kind of stuff? American Academy of Pediatrics says don't routinely change the formula to a soy-based formula. However, a certain small number, 10, 15, 20% of kids are lactose intolerant. You don't know who they are. It is not predictable. So it's not unreasonable to say, listen, start the kid on a soy formula for a week because you don't know what percentage of them or who those kids are. So fine, it's not a big deal to say, okay, let's take some new soy for a week instead of your milk-based formula. That's it. The severe dehydration kids, it's normal saline, normal saline, normal saline. It is not half normal, not quarter normal. All of those complex things that we knew about kids, it all went away. It's normal saline. And it doesn't matter whether the sodium is 160 or 130, it's normal saline. The other thing is that the kids are calorie deficient, so it wouldn't be inappropriate to go D5 normal saline until they basically give them, although the amount of sugar in D5 is nominal. It's 5%. 5%. It's 50 grams. A liter of normal saline is 50 grams of sugar, which is 200 calories. It's nothing. It's nothing. You eat one little candy bar, you've made more of the sugar than in a liter of normal saline.
The amount of IV that you recommended there seems pretty standard with textbooks I've always read, but I don't know, I'm opening up this question to everybody. Every time I follow what's written in ER handbooks or even pediatric handbooks, pediatrician always tosses out too much fluid. I'm being too aggressive. In different hospitals where I worked, and I don't know if everyone has had that too. Pediatricians get nasty on your.
All of this stuff basically is CDC, World Health Organization. There's more consistency than not. They want to make it simple. That was too complicated before, kind of thing, and they basically concluded that's why most people think it's kind of hard. It's really surprisingly easy.